Now we are going to hear from Dr. Michelle Cow. Dr. Cow is a clinical associate professor in the Division of Sleep Medicine and the Division of Neuromuscular Medicine at the Stanford University School of Medicine. She is a board certified in pulmonary, critical care, and sleep medicine. Her expertise is in the complex sleep-related respiratory disorders and home mechanical ventilation for chronic respiratory failure symptoms. So thank you so much for being with us today. I will turn it over to you.
Great, thank you, Nicole. Thank you for the introduction. So I am Dr. Michelle Cow again, and I work at Stanford University, and I direct the home mechanical ventilation program for the neuromuscular program there. So I'm going to talk about respiratory care in myotonic dystrophy, and I have no conflicts of disclosures. That's part of this talk. So the agenda today is to discuss signs and symptoms of respiratory weakness in sleep as well as daytime, discuss the testing for respiratory weakness, and lastly, review the treatment options for respiratory weakness, including non-invasive ventilation. So as you know already, myotonic dystrophy is a multidisciplinary approach. So you have many specialists involved as part of the team. So your neurologist is going to be the primary driver here. And then there's a pulmonologist like myself. Sometimes we are both pulmonologists and sleep specialists. At other locations, you could have a separate specialist for each category. And then there's social worker, genetic counselor, as well as very important occupational therapy, physical therapy, speech therapy, and respiratory therapy. It's a multidisciplinary team approach, and as you can see here, there are many different multiple providers involved in taking care of a myotonic patient. Next slide. So in terms of breathing in myotonic patients, there are multiple areas that we focus on. So you can see here that there's sleep-related respiratory impairment, there's daytime, as well as there's also airway clearance, inability to basically, like, for example, clears secretion, sputum, and so forth. And then there's also swallowing impairment. So all of this can lead to respiratory failure, and the goal is to prevent this from happening. Next slide. So I just want to give you an overview of what happens with respiratory weakness, right? So initially, this happens during REM sleep, which some of you may know as deep sleep. And as the condition progresses, it becomes a problem during all stages of sleep. So during sleep, there's evidence of breathing problems, and then this eventually progresses to daytime. Next slide. So respiratory involvement in myotonic. So there's three areas that we cover. So respiratory muscle involvement. Usually this is the diaphragm, which is the main muscle of breathing, and it is most critical during sleep that we support the diaphragm. For sleep disorder breathing, this is where we have development of high carbon dioxide and low oxygen levels in the blood, and this will progress to daytime if we don't address it. And then there's also impaired cough and inability to expectorate or clear secretions. And this can lead to lung or parts of the lung lobar collapse, as well as aspiration, leading to pneumonia. So the goals of intervention, right? So we want to preserve lung function. That means that we normalize oxygen levels, we normalize carbon dioxide, we improve the chest wall and the lung function. We want to improve quality of life so that care at home can be much easier. We want to decrease the work of breathing. We want to rest those muscles so that your strength can be used elsewhere, and optimize your sleep so that we can improve quality of sleep. And also we want to help with when you have an illness, that we want to make sure that you don't get hospitalized or have to go to the emergency room. And last but not least, want to prevent tracheostomy as the end stage treatment. So this is a nice diagram. It's a little bit complex, but if you look at it, there's three categories that I talked about. There's muscle weakness when you breathe in, which is inspiratory. There's muscle weakness when you try to breathe out, which is expiratory. And bulbar muscle are the muscles of the neck and the face that can be weak. So all of this can cause breathing problems, cough dysfunction, and upper airway dysfunction, which is basically your windpipe closing down during sleep. So all this leads to basically respiratory failure, as well as pneumonia. So they all intertwine and interact with each other. So what happens during sleep is that So you start out with having some degree of diaphragmatic weakness or breathing muscle weakness. This causes a reduction in oxygen level and an increase in carbon dioxide during deep sleep or REM sleep. Because of that, this leads to frequent arousals and sleep fragmentation. That leads to poor quality sleep and a total reduction in sleep time and sleep efficiency, which leads to daytime sleepiness and then eventually also daytime respiratory failure. So this is the cycle that we try to break. So why do patients with myotonic have breathing problems during sleep? So in normal sleep, even in someone without myotonic, there's already changes in breathing. So there's reduced lung volume, there's reduced muscle strength. The breathing depends on the diaphragm during deep sleep. Even in a normal person, carbon dioxide levels are a little higher and oxygen levels are a little lower. And the throat muscles are weaker just because of sleep. And when you add the diaphragm, when you add the myotonic, breathing problems, you have diaphragm weakness, you have muscle fatigue, you have even lower levels of oxygen and higher levels of carbon dioxide. You have more pronounced obstruction in your throat, and then you can't, there's problems with clearing the secretion. So this magnifies the breathing issues during sleep. Go ahead and advance it. Keep going. So some of the symptoms that you want to look out for is that during the nighttime, people may complain of frequent arousals, difficulty staying asleep, and then some may think that they have insomnia. There's also unrefreshed sleep. You wake up in the morning and you feel like you didn't sleep very well or didn't sleep at all. Some patients may sleep longer in an effort to compensate for the poor sleep. And then there's also snoring, which is a sign of upper airway obstruction. And then also those breathing pauses, gasping or choking, and these are signs that you may have sleep apnea. During the day, the symptoms also can be very nonspecific, but you have to pay attention because they can point to a breathing problem during sleep. So there's daytime fatigue and lethargy. People may have daytime sleepiness. People may complain of exercise, reduced exercise capacity, and mood changes, cognitive impairment, and frank shortness of breath if the weakness is severe. This is some of the testing that we do for breathing weakness. So when you come to the clinic, we normally do the spirometry. That's the pulmonary function testing. This is a test that we do routinely for all patients, and we try to do it every 6 months or even closer, depending on the patient's weakness. There's also respiratory muscle pressures. This is that MIP and MEP, and then the peak cough flow, which is PCF, and all these are testing different tests that you probably are familiar with when you come to the neuromuscular clinic. So sometimes we have a normal spirometry, but the MIP can be low, and that signals that there might be early diaphragmatic weakness. These other tests we consider, but it's not routine for us. So for some people, we actually recommend a sleep study, especially if the breathing test during the day is normal. We want to make sure that nighttime breathing is not a problem. And correspondingly with the sleep study, we can also measure CO2 levels. We can also just do a quick screening test, which is that nocturnal, that pulse oximeter that you put in your finger, which just measures oxygen during sleep. And then obviously we can do arterial blood gas, which is a blood draw. It is a specific test that we can only do in the pulmonary function lab in the hospital setting. So it is a little bit more cumbersome to get that test. We can also do the HCO3 is a bicarbonate in the blood, and it's a surrogate measurement of CO2, which is much more easily done because we can just do a quick blood draw in the regular lab for that. And then for some patients, we actually need to do imaging such as a chest x-ray or a CAT scan of the chest, and then even echocardiogram, which is the ultrasound of the heart. Keep going. So the pulmonary function testing, many of you have probably already gone through this, but as you know, the lab is actually located in the hospital. In certain clinics, we do have the respiratory therapists come to the clinic to do this for us so we can save patients an extra visit. These are the measurements that we do. We do the FVC, which is a global measurement of respiratory strength. It's called forced vital capacity. The MIP is a maximal inspiratory pressure, which is also another measurement of muscle weakness or muscle strength. And then the MEP is is a measurement of expiratory pressure. So how strong is your cough? How strong are your muscles in terms of breathing out? And then the peak cough flow, we measure that indicate if there is evidence of a weak cough, which would signal that the patient may have a problem with clearing secretions. So this is really the first step. All patients should get this test done. So normal values for these numbers here. Can you just advance the slide? Okay. So here are the progression. So this is the progression of the FVC. So the FVC is your main test for breathing, and it's again, it's the global assessment of respiratory function or lung capacity. And you can appreciate the sort of what happens here. So that if your FVC is greater than 80% predicted, this is considered normal range. When it falls to about 50%, above 50%, this is when patients already have evidence of breathing problems during sleep. And then when it falls to below 50%, around 40% or more, patients clearly have evidence of sleep breathing issues, as well as early daytime problems. And then when it's below 20%, these patients are considered to have daytime respiratory failure. When you're at 20% or less, most patients cannot breathe on their own without respiratory support. Now, when you have a respiratory infection, that will magnify and it can lead to more rapid progression of the FVC decline. So in terms of the sleep study, how does this fit in? I think many people end up getting a sleep study, and it depends on where you're seen. But I think a lot of patients will ask me, when do I do a sleep study? How does it fit in? So a sleep study is not the first test, as you have heard, but it is a valuable tool if necessary. So it identifies breathing impairment during sleep. It can help in terms of provide settings on the respiratory device for certain patients. And for patients who are already on a non-invasive ventilation, such as a BiPAP, it can also help identify certain breathing problems related to the BiPAP itself. Now, for myotonic patients, we do the overnight sleep study to look for sleep-related breathing problems, but we also couple it with a daytime nap test called the Multiple Sleep Latency Test, MSLT. And this is basically a nap test, 5 naps during the day that objectively tests for evidence of pathologic daytime sleepiness. Now, so the sleep study overnight is for breathing. The nap test during the day is to test for sleepiness secondary to chemical changes in the brain that can aggravate daytime sleepiness. Next slide. That being said, I think the sleep study is valuable, but I recommend, we never want to delay treatment with a BiPAP or non-invasive ventilation while waiting for a sleep study, especially if the patient qualifies for a BiPAP device based on the pulmonary function testing. Okay, so let's talk about interventions and treatment options. So for both nocturnal and daytime hypoventilation, which is basically low oxygen levels and high carbon dioxide levels, we recommend the use of non-invasive ventilation, which we call for short is NIV. You may know it as a BiPAP device or something more advanced than a BiPAP device. For impairment with airway clearance, this is when we recommend either manual or mechanical cough assist therapy. So NIV, it has several advantages. It clearly alleviates respiratory symptoms. It improves quality of life, and there is a survival benefit as well. So it is important that patients get offered this treatment if they qualify. So I break it down when it comes to respiratory treatment. I break it into 2 categories. There's assisted ventilation, which is assist with breathing, and then there's assisting with airway clearance, right? So NIV, again, as I mentioned, it improves gas exchange. I mean, it improves the oxygen level, it improves the carbon dioxide level, and it minimizes chest wall distortion. It can prevent that if started early on for certain patients. It can relieve workup breathing, and we use advanced devices. We don't use the basic BiPAP devices or especially CPAP. So here it is, what I said here is, this slide, actually, I use it for another talk and it doesn't apply to non-sitters and non-walkers, but we don't use CPAP for myotonic patients with any evidence of lung capacity involvement. So unless you have completely normal lung capacity, we do not use CPAP. And we also don't use oxygen as well, because using oxygen alone can aggravate the carbon dioxide retention and aggravate the respiratory impairment. So for airway clearance, for manual ways, we do oral suctioning, we can do chest physiotherapy, we can do airway hydration. The majority of patients will go on to mechanical airway clearance. So this is basically that cough assist device that we recommend. And we also can do airway clearance if patients are on a ventilator, and we use breath stacking methods to help with airway clearance. And the one advantage of mechanical airway clearance is that in addition to improving airway clearance, we can also use it for lung volume expansion. So we can prevent atelectasis, which is where the areas of lungs can collapse from lack of use. So a lot of patients will ask me, there's a lot of different devices out there, and we all, use this common term as BiPAP, but actually there are a lot of different, devices, and depending on where your disease is at, we decide which device to use. So I like to break it down again to two different categories. So if you have isolated sleep problem, meaning that your breathing impairment is primarily in sleep, then we use what we call respiratory assist devices, or RATs. These are your BiPAP devices. So this is where that BiPAP term comes in. But these are advanced BiPAP devices, not the ones we use for sleep apnea. These are devices with a backup breathing rate that can help the patient to breathe better during sleep. And then these are some of the advanced modes, as you may be familiar with, but a lot of patients were asking about these different modes, such as AVAPs is a common term, and it's basically a very advanced BiPAP device that can guarantee that each breath that you take, you have enough air exchange. So for patients with daytime respiratory failure, these are patients who have evidence of high carbon dioxide during the day, low oxygen during the day, and some patients cannot breathe on their own during the day. We use the ventilators. They're portable because they don't require electricity. Unlike the BiPAP devices, you need electricity. So these devices are portable, and so if you lose electricity, these devices will still work. So these are different devices out there in the market. They have the same modes and setting as the BiPAP devices. The added benefit here is that some of these devices have what we call mouthpiece or SIP ventilation for daytime use. Next slide. So which device and mode is best for me, right? So again, this basically depends on your severity of your disease. So again, in early stage, when your FVC is, let's say it's relatively normal, but you have evidence of sleep-related breathing problems, then I start out with a BiPAP device. And for a patient who is naive to BiPAP, we use low pressures to get the patient to acclimate to the device before we go up in the pressures. For patients with more progressive, advanced respiratory failure, we go straight to the ventilator. Next slide. So these devices are actually really pretty neat in the fact that, when you get on the device, the clinician or the provider will be able to monitor your usage and how you're doing on it, right? So these devices, they have a cell modem. And what they do is that they record the breathing during sleep, and they upload the data to a secure cloud, and the provider who is treating the patient has access to that cloud. So when you, for example, if you see me in clinic, I will access this, your device remotely, and I can see if you're using it. I can also see a lot of good data, such as, is the mask fitting properly? What are the pressures that you're using? Are there any residual breathing problems? Like, are you still having apneas or breathing pauses during sleep? Next slide. So it does give me a lot of data, and I can help. So it helps me guide management in terms of, do I need to make changes on the settings, that kind of stuff. So it's very important that the provider does access your device and analyze it and make adjustments as necessary. So insurance requirements. So this is, patients deal with this a lot. So I wanted just to put it out there so you are familiar with the concept. So for the bi-level devices, these are your respiratory assist devices, right? Now, there's a Medicare and all insurance, third-party insurance. They have this policy called 90-day adherence or compliance requirement. What this means is that in the first 90 days of use, so day one is when you get your device, the patient needs to use it for 4 hours minimum per night, and 70% of use in a 90-day period. So what that means is that you have 90 days to demonstrate that you can use it for approximately 30 consecutive nights. So they're looking for that 30 consecutive nights. Every night is 4 hours minimum. So for example, if you use it for 1 week straight, and then you stop using it for another week and you go back and use it again, that does not count because it wasn't consecutive. And 4 hours of use is not going to help the patient, but this is the minimum that the insurance is asking. And it doesn't have to be continuous 4 hours. So for example, if you want to use it during the day for an hour, in the evening for another hour, and then 2 hours later during sleep, that would count as 4 hours. But this is basically the 90-day compliance that every insurance will look for when you have these devices. And the second criteria is that you need to have a face-to-face follow-up with the provider who prescribed it. If these two criteria are not met at the end of 90 days, your insurance will stop treatment and you need to return that device. For ventilators, it is surprisingly and oddly less strict. So none of these criteria, the 90-day adherence requirement does not apply to ventilators. However, I will say that certain insurance policies are adopting this requirement. Next slide. So what about CPAP? As I mentioned before, CPAP is absolutely contraindicated in myotonic patients. Really, unless your condition is very mild and you have really just obstructive sleep apnea. But otherwise, CPAP really increases work of breathing. It causes diaphragm fatigue because if you think about it, CPAP is this continuous positive pressure that's just blowing in no matter what. So when you're breathing in, it helps to bring air in your lungs. When you're breathing out, you have to breathe against that pressure. And so the diaphragm can become very fatigued during sleep. Next slide. What about oxygen? So I'm so sorry again, I did not look at this slide closely, but I used this slide for another talk. But so oxygen again is the fundamental problem with all neuromuscular disease, including myotonic, is that it is a diaphragm and it's a respiratory muscle weakness of the diaphragm and all the other respiratory muscles involved. So it leads to the inability to basically get enough air exchange in the lungs. So it is difficult to get enough air in as it is, and also much harder to even exhale carbon dioxide. So what happens here is that if you use oxygen, then you might be falsely reassured that your oxygen level is high because it's going to be high because you're adding oxygen to the air that you're breathing. However, you're not excreting carbon dioxide. So because of that false sense of security, patients think they're doing okay, but what happens is that when the carbon dioxide gets too high, it leads to loss of consciousness and respiratory failure. So you should never use oxygen alone, even if you're having acute shortness of breath. Oxygen should always be added to the non-invasive ventilation device, whether it's a BiPAP or a ventilator. What else to avoid? So you want to avoid medications for sleep if possible, the hypnotics for supposedly insomnia, such as benzodiazepines, and then narcotics, especially for pain control, like morphine, MS-Contin. Those medications are very toxic to breathing because it actually suppresses the breathing control center in the brainstem. And so myotonic patients who use these medications will breathe much weaker. And remember, at baseline, breathing is already weak. So now your breathing is weaker. So you have less oxygen levels and you even retain more carbon dioxide. So this is a really bad condition. So I see my patients, what happens is that, they're doing fine. And then let's say they break their arm or they have something that happens to them acutely. They had a fall in the house, they go to the ER. And then of course the ER provider gives them pain, pain medication and then also some patients have muscle relaxants. And so that can just suddenly put them into acute respiratory failure. Next slide. So I wanted to talk about just a brief slide on mask fitting. So mask fitting is a huge issue when it comes to non-invasive ventilation use, and many myotonic patients have problems with the mask fit. Unfortunately, there is no custom-made mask yet, but I think that's coming in the future. So as of now, these are the mask options. There's the pillow mask, the nasal mask, the full face mask, which covers the nose and the mouth, and then this total face mask, which we don't use very often. A lot of patients have mouth leak, right? Myotonic patients have a hard time closing their mouth. There's a lot of nasal obstruction, so a lot of patients breathe with their mouth. These are also other factors that can increase mouth leak, so the obesity, aging, and just being male. So you can see here in this, oh, I'm sorry, can you go back? So quickly here, nasal mask and the advantages. I always start my patients with a nasal mask. There's so many more advantages compared to a full face mask. There's a lot of disadvantages of full face mask. It's less comfortable, there's a higher leak. It can increase aspiration risk. It can put air into the stomach. So a lot of issues with full face mask. So even if you're a mouth breather, I go with the nasal mask first. Next slide. Okay, so these are just some different mask options. There's many out there, but this is the pillows, which is really I would say the least intrusive, the smallest style mask. This is the full face mask where the patient, the nose and the mouth is covered. This is a nice mask because it doesn't really hit the nasal bridge. So a lot of patients have skin break down the nasal bridge, and this can help with that. And this is another type of nasal mask, also pretty, not very intrusive. Next slide. So remember that all masks are interchangeable with all devices. So a lot of patients ask me, well, I'm using this mask, I'm changing the machine. Can I, do I have to change my mask? No, all the masks are interchangeable. So you can use any mask that you like with any device that you want, okay? So the rule here is just choose the best fitting and the most comfortable mask, because the most important issue here, or the most important point here, is that you can use the mask and wear the device all night. So again, some other options here. Next slide. Again, these are the full face mask options here, right? So again, we try not to use those triangle masks nowadays because it causes skin breakdown the nasal bridge. So these are the different options we use where it doesn't have that problem. So some of the side effects related to masks, right? You all experience this if you use it. So there's mask leak, there's nasal congestion, dry mouth. There's, like I said, this is very common, that skin irritation or skin breakdown the nasal bridge. If the pressure is really high, people can't breathe. And then also there's a lot of anxiety around mask wearing, which can cause more fragmented sleep. Next slide. So some of the options that we recommend, so for nasal bridge, we try to go away from that triangle mask in the first place, or even the nasal mask that's like a triangle. But if you had to, then you can use these there's different options you can use here. There's this thing called Gecko gel pads, which is that middle photo here. Some people use Moleskin. There's this company that makes Ramsey mask liners, and they're actually really nice. I think this is probably the best option is the Ramsey mask liners. They're mask specific. They're very thin and they're like it's made of a cloth and it's very comfortable. So I think a lot of patients, if they have issues with their skin, they use the Ramsey mask liners. So these are just some solutions to mask issues. So if there's skin breakdown irritation, you might have to get a different mask. Like I said, we try the nasal pillows mask first before we try other masks that puts pressure on the nose. If there is skin irritation, eye irritation, you have to refit the mask. If you have air blowing in the eye, then that is not, something's not right. But some patients have dry eyes, so we can use saline eye drops. And if you want to put an eye mask over first, then that would take away the problem with the air going into the eyes. Mouth leak is very, very common. Chin strap is an option. But I think like having to wear a chin strap and the mask is, now you have to wear two things. So it can be cumbersome for some patients. If mouth leak is a really big issue and it disrupts sleep, then we have to switch to a full face mask. And again, if there's any kind of discomfort, we just have to refit or switch mask. Next. Nasal congestion is a big problem. So we try to use heated humidification that's on the device. You can use nasal saline sprays. Sometimes we add nasal steroids, decongestants, and antihistamines because some of these patients, I think that you have underlying nasal allergies, and then when you add the PAP device and that air blowing into your nose, it can irritate the nasal lining more. And some patients have, actually many patients have a lot of anatomic obstruction, like your septum is deviated, or those terminates, those filters in the nose are really enlarged. And so in that case, we have to ask our ENT colleagues to help with the obstruction. Bloody nose just means that the air is really dry. So we increase the humidity, the moisture level, and we can add saline drops. And then running nose, again, the positive airway pressure can really irritate the nose. Then we increase the moisture level. We can use saline drops, antihistamines. And then some devices have the option of warming the air up before you put the mask on. Aerophasia is also very common. This means that air is going to the stomach instead of the lungs. what we recommend is that we reduce the air pressure. You have to do that. We also want to elevate the head of the bed by 30 degrees if possible. And that's going to help guide air down to the lungs instead of going to the esophagus and to the stomach. Claustrophobia is very hard. This is just, you have to acclimate to use. So we try to use the smallest mask possible, which is the nasal pillows. And I recommend for these patients that you just put the mask on during the day for maybe 30 minutes or so and get used to it, and you build up your hours of use before you start using it for nights. Difficulty exhaling. This means that the pressure is too high and we have to reduce the pressure. Next slide. Noise. Okay, so noise is a problem. However, I will say that the new devices are pretty quiet as long as there's no leak. But we try to move the unit away from the bed as much as possible. But given that there's that tubing, so you can't go too far away from the bed. Tube condensation. So this doesn't really happen too much if you have a new model, because there's a climate control in these tubing now. But for the older models, this may happen. Also, if you use a manual mode of moisture control, that may happen because what means that you're just increasing the temperature and the moisture level too high. There's this thing called a snuggle hose, and basically it's like a fleece for the hose if you really have to use it. But I think the newer models now really don't have this issue anymore. Partner intolerance is always hard, right? I mean, you just have to figure out, somehow how you can use these devices in your bedroom and not, bother your partner too much. And I think some education also helps if the partner is really engaged in your care. Portability. Okay, people who need to travel or patients who, for some reason, you need to, you're traveling a lot for whatever reason, then you might have to switch to a portable ventilator because, like I said, their electricity is not required. So again, always start with the pillows or nasal mask before a full face mask. Full face mask has a lot of side effects here. If you have nasal obstruction, it is very hard to use A&E PAP therapy. So if I see a patient with significant nasal obstruction, I have to get this corrected before I initiate PAP. Otherwise, the patient's never going to tolerate it. I always use heat humidification and moisture in the PAP devices or the ventilators. You can add a chin strap if there's mouth opening or before you switch to a full face mask. And I think it's important to engage the caregiver and the bed partners in the mask selection. And last but not least, I try to work with responsible and receptive durable medical equipment providers. Sometimes you don't have a choice, but you try to. So lastly, I want to talk about cough assist. So for our patients, I think using a BiPAP is one thing, but the other big category is obviously being able to clear secretions. Otherwise, you end up having pneumonia. So this is a nice term from, nice phrase from John Bach, who was it's a prominent neuromuscular clinician. So aspiration prevention. Okay, so we try to always sleep semi-upright with the head of the bed on an incline. And I think this is great for everyone, not just even myotonic patients, but we recommend that if possible. Good daily oral hygiene practices so that you don't have, aspiration concerns and pneumonia. Aspiration risk is always an issue depending on the patient's severity, but these are the options, right? So you can change food consistency, speech therapy, airway hydration, and we can use oral suction devices. So airway clearance, the benefits, in addition to cleaning drainage of secretions, right, it's lung volume expansion. So we really try to prevent lung collapse. Good airway clearance can prevent tracheostomy because it prevents acute respiratory failure leading to tracheostomy. These are the options again. So mechanical cough assist, this is what we probably know as most is that device that helps with cough therapy. Not many patients do this, but some patients have it, which is the vest therapy. This is more of a intrapulmonary, it's a percussive device, and it helps to mobilize your secretions in your lungs, but we don't use this alone. If you're going to use a vest, you still have to use it with the cough assist device because you can mobilize secretions in your lungs, but how are you going to bring it up? And when you have weak respiratory or cough muscles, you can't bring it up. So the vest is always followed by the cough assist. Nebulizer therapy. We use that for people with acute infection to help with airway clearance, to help with, shortness of breath and so forth, but not always on a routine basis. So again, here is that the cough assist. So I think it's really important to use cough assist at least twice a day, just as a maintenance. So just, as if you're brushing your teeth twice a day, you want to use it in the morning when you wake up to clear junk out of your lungs, and you want to use it before bedtime. When do we initiate mechanical cough assist? So when you come to the clinic and we do these breathing tests, we also do the peak cough flow. And this is the number, sort of the where we initiate mechanical airway clearance is when you have a 270 less. If your peak cough flow is less than 270 liters per minute. When the peak cough flow is less than 160, this is really a big concern, because these patients are very weak and they cannot protect their airway, which means they're acute for respiratory failure. Next slide. So some of you may know this, but there's different ways of cough assist, right? We generally go straight to the mechanical cough assist, which is this is one device right here. But you can also use manual devices, right? You can use the ambu bag, and you can use breath stacking. And so you basically inflate your lungs up to full capacity. And so then when you cough after that, there's a lot more air in your lungs. So it helps to build up that pressure to help when you do that cough. And for people on the ventilator, there's also a mode that we use, and this is not BiPAP. You can do this with BiPAP, but we can also do breath stacking with a ventilator. Next slide. So this is what I tell all my patients, right? So in the home setting, you want to make sure you have a care plan, right? So what to do every day, and if you have to go to the hospital. You want to know when you need to go to the ER. Right. So what are your thresholds and what are the criteria? So this is a discussion with your doctor. And if you have to deal with EMS and acute care providers in ER, most providers will not be aware of your needs. So it's really important to have your protocols, what you do at home, and your advanced directives. In the hospital, I recommend that our patients always bring their respiratory devices. Even if you can't use it, you want to bring it. And I really advocate for the caregiver to stay with the patient if possible, because your caregivers are going to know more about your care than the providers in the hospital. For people who are undergoing anesthesia, tertiary care tertiary care centers are probably better at myotonic management. There's always a difficult airway evaluation if you need anesthesia and intubation. I recommend that our anesthesiologists monitor CO2 for any procedures. Minimize sedation, anesthesia, opiates as much as possible. Really try to do aggressive airway clearance while you're in the hospital. And I try to tell the providers in the hospital, please avoid oxygen without using NIV. And then, so let's just summary. Let's go over what we talk about here. So always seek evaluation for nighttime and daytime symptoms, right? If you have any of these symptoms, it may mean that there's a breathing problem during sleep before it manifests into the day. You want to monitor your lung function regularly. So that's probably every 6 months, sometimes every 3 months. And it is important to use the non-invasive ventilation device and choose a good mask so you can wear it every night, and work with your DME company. If your cough strength is impaired, it is recommended that you really try to get to learn how to use the cough assist device so that you can prevent pneumonia and acute compromise. If you're hospitalized, you want to advocate for early NIV use and airway clearance as soon as you're admitted. And lastly, don't forget to get your flu shot every year, and of course the COVID vaccine. I think this is it.
Yep. Thank you very much,
Okay.
Dr. Cao.
Sure.
That was a lot of information. We've got quite a few questions here. Is a borderline sleep study normal?
Is a borderline sleep study normal?
Yes.
Well, so I will say a sleep study is a double-edged sword, because sleep studies are designed to evaluate for obstructive sleep apnea, right? So the problem with sleep apnea is that if you have sleep apnea, the provider is going to recommend CPAP, and CPAP is contraindicated for most myotonic patients.
Okay.
So I would say that a borderline sleep study probably means that there's very mild respiratory abnormalities. So I would probably say not normal, but probably don't need to be treated for a myotonic patient.
If you have mild, if you have a mild version of myotonic 1, how likely are you to have respiratory issues?
If you have mild myotonic, your respiratory issues will probably be very mild, and you probably have a very slow progression. That
Okay.
being said, I still recommend sleep evaluation because
Mhm,
you may just have isolated sleep disorder breathing.
mhm.
And then the other thing is that, especially if you ever get procedures done that requires anesthesia, these are the patients where they do fine, but when they get anesthesia, they have complications because those patients tend to have isolated REM hypoventilation, which is when you have elevated CO2 and low oxygen levels only in deep sleep. So
Okay.
if you get anesthesia, you can really go into acute failure.
Okay. Does sleeping with an AVAP remove enough carbon dioxide to keep CD levels safe?
To keep what level safe?
Carbon dioxide levels safe?
Yeah. So an AVAPS is just a very advanced mode of BiPAP.
Mhm.
So I would say getting on a non-invasive ventilation device, BiPAP is one type of device, but more correctly, getting on the right setting and the right pressure and the right mode is going to prevent CO2 elevation or CO2 buildup in your blood.
Okay.
So it doesn't have to be AVAPS. It has to be the right device and the right settings.
Okay. This person says they have DM1 and use melatonin to help me sleep. Is there any danger to this? The only breathing assistance device that I use is a cough assist.
Okay. I think it's a little odd that I assume the cough assist is being used because the peak cough flow shows weak expiratory or cough muscles. I think it is odd to have isolated weak cough muscles but not have weak respiratory or breathing muscles. But
Okay.
anyway, melatonin is fine. It is really melatonin is not, it's not FDA regulated, so there's many different options out there in the market over the counter. As long as you're using it just to help you fall asleep in the beginning of the night, it's probably fine and probably not a big deal.
Do you recommend anything for insomnia?
I don't recommend medications. I think
Okay.
if you have insomnia, we need to really evaluate your sleep. Is it because you wake up a lot because of breathing issue? Is it because is it because you have a circadian? Circadian is basically the internal clock in our brain that regulates our sleep and wake patterns. Is it because you have a circadian clock dysregulation, which is very, very prevalent in myotonic patients? So you really need to dive deeper into the reason why you have supposedly insomnia before I can say it's
Sure.
insomnia.
Okay. This person says their sleep specialist recommended Somnifix tape to keep the mouth closed, but they said not to use it with low blood pressure and heart issues. Do you have any recommendations or have you heard anything about that?
I don't know what Somnifix is. I
Okay.
can Google it really quick, but I don't know what that is. I've never heard
Okay.
of it.
And I'll just ask too if Amy wants to
Oh, the
comment. Yeah.
mouth strips. I see. These are basically it's a fancy way of putting tape over your mouth.
Okay.
So are we doing it because you're on a BiPAP device and you have mouth leak, or are we doing it
Okay.
just to keep the mouth closed during sleep?
Okay. If Amy could comment on that, that would be great.
Yeah.
Could you explain to a couple of the viewers what exactly the vest is?
Yeah, so if you've ever worn the vest before, it's basically, so it is like it's like a vest, right? But once you turn it on, it causes a very high frequency percussion. So it basically shakes your chest very high frequency for about 15-20 minutes. You can program all this, of course, in terms of how much shaking is happening and how long do you want to use it for. So you can think about it, like for example, when you can actually, like manually, use the palm of your hand and, kind of basically, percuss the back of a patient, like the patient's back, right? To try to like loosen up, secretions and phlegm and so forth. The vest is a mechanical way of doing it. So you can imagine if you're shaking your lungs, you basically sort of, so if the phlegm and the secretions are really tightly tiered to the lung wall, you're basically kind of mobilizing, so to speak, the secretions in the deeper areas of the lung so that you can cough it out effectively. right?
Okay.
So, but the problem is that myotonic patients, just like any other neurological patients, have problems with coughing, right? Because their respiratory muscles are weak. So you can mobilize the secretions, but then you can't cough it up. And what's going to happen now is you have all these secretions in your lungs that's out in the open, the larger airways, and then you can't cough it up. So
Okay.
whether you have a vest or not, it is critical that you still use a cough assist. So majority of insurances will not cover the vest and the cough assist. So if you have to choose one, it's always the cough assist.
That's a good point. Always have to think about insurance.
Yeah, I know. And I think, I use the vest. I mean, there are patients whose insurance will cover both, and I would use both, but majority of time I have to pick one or the other. So it's going to be the cough assist.
Okay. This person commented, my son could not tolerate the BiPAP due to air pressure, and he has been
Yeah.
switched to CPAP. Listening to you, I'm wondering and worried now if this may not be the best choice for him. He has DM1, mild sleep apnea, and during his sleep study, oxygen was between 92 and 93%.
Yeah, so that's pretty mild, right? So your oxygen
Okay.
level above
Sure.
90% during sleep, it's pretty mild. Maybe he does have isolated sleep apnea, and then the CPAP is okay. But then I wonder, why did he go on BiPAP in the first place? So the provider must have noticed something that required BiPAP. I tend to say that in general, the pressures between a CPAP and a BiPAP are the same. They both can be very high, they both can be very low. But the difference between the BiPAP is that when you breathe in, it can give you the high pressure to bring in air. When you breathe out, it drops the pressure so that you can exhale on CO2. So why not just drop the BiPAP pressure instead of going to a CPAP?
All right.
Because the CPAP pressure can still be higher than a BiPAP pressure.
Okay. Okay. Makes sense. Amy commented about the Somnifix tape that we were just talking about. She said it's for severe mouth drop, and she has a huge struggle with that.
Yeah, that is a problem with myotonic patients, and really a lot of problem with sleep apnea patients too. I think it's fine to use it as long as you're not dealing with a lot of airway clearance. Some people have
Mm-hmm.
a lot of drooling and difficulty. They saliva issues, and they're always sort of like trying to clear their saliva, right? So I think if that's an issue, then it's a problem because you can aspirate, right? Because it can go backwards, and
Sure.
because there's no way to come out. But if
Yeah.
you don't have that problem, then it's probably okay to use.
Okay. Is CPAP okay to use for DM type 2?
Again, it comes back down to what is your lung function and what does the sleep study show.
Okay.
It always comes back to that.
What blood oxygen levels is measured by a pulse oximeter during the day? Okay. Ryan, if you could maybe type in a little bit more to your question, you can elaborate on that. This person said, my 19-year-old daughter with DM just had a CPAP prescribed based on mild sleep apnea. This was managed by her neuromuscular doctor. I think what I'm hearing is we should seek a pulmonologist that will do further evaluation and possible switch to BiPAP. They started with a full face mask because she is a mouth breather. Should she switch to
Yeah.
nasal?
If she's tolerating the full face mask, that's perfectly fine. I would keep with it. But if she's having a hard
Okay.
time, then I would go to a nasal mask. I wouldn't say that you should see a pulmonologist right away. A lot of pulmonologists are not familiar with myotonic treatments.
Mm-hmm.
So and unfortunately, there aren't a lot of pulmonologists who do neuromuscular respiratory care either. So I would make sure that she doesn't have any. I mean, I'm assuming her lung capacity is okay during the day, because if her lung capacity is abnormal, then definitely she should be on CPAP.
Okay. Ryan commented about the blood oxygen levels,
Yeah,
SpO2 levels between 80
yeah,
and 91 during the daytime. Is that a problem?
that is a problem. That is very low.
Okay.
So especially during COVID times, I recommend all my patients get that pulse oximeter, right? You can purchase it over the counter anywhere. You want to be a normal individual, always 97, 98%. When you're in the low 90s, something is wrong. When you're
Okay.
dropping below 90, something is really wrong. Now, it could be that you're chronically down there, which means that your patient, the patient is chronically not breathing. And so the body is compensated over time. So I assume this patient probably has probably very low levels of oxygen chronically and high levels of carbon dioxide chronically. And the body does compensate and adjust to that. So over time, you just live with that. But the problem
Mm.
is you have no reserve now. So all it takes
Okay.
is a bronchitis or a flu, and then you basically go into respiratory failure.
Okay. Yeah, that's not good. Um, This person says that their son has profound respiratory muscle weakness and he uses a Trilogy machine. Should he fly?
That's a hard question. So the Trilogy machine doesn't profound respiratory weakness doesn't preclude you from flying or traveling. The question
Okay,
is, do you have enough caregivers to support you when you're doing this?
sure.
Because it takes a lot of effort. But yes, you can fly and you can travel even with profound respiratory weakness.
Okay. Is hyperventilation common in DM1 or is it strictly an anxiety response?
Hyperventilation, like
Mhm.
not hypo, correct? Hyper.
Correct.
No, it is not common. It's
Okay.
more, I would think it's probably of an anxiety response.
Okay. And just to touch base again with Amanda who asked, she says that she was a borderline during her sleep study. She's asking, should she ask for another one? Should she do another sleep test?
Um, no, but I wouldn't do it for at least another year or two. But I would definitely do
Okay.
the lung capacity, and I'm assuming this particular person's lung capacity is normal.
Mm-hmm. I'm assuming.
Yeah.
Yeah.
So then I would probably repeat lung capacity once a year and maybe a sleep study once a year. But no need to repeat it now.
For anyone with myotonic type 1, how often would you recommend them see a pulmonologist?
Well, it depends. I mean, if they're on treatment, then they should be seeing the pulmonologist probably twice a year, every 6 months. Um, I'm not sure. I guess if you haven't seen a pulmonologist, you probably should. But you know,
Yeah.
a lot of the neuromuscular programs, they have someone that they refer to, or they can manage
Mhm.
this themselves. So it just depends on where you live, I think.
Yeah, and who
Like
they
I said,
see.
not every pulmonologist are familiar with myotonic patients.
Mm-hmm. Okay. And our last question I'll take due to time. This person says their kids get hiccups a lot and pretty bad. Is this due to a weak diaphragm of DM1? Severe
Oh,
hiccups?
I don't know. I actually don't know. I
Okay.
don't know that hiccups is due to diaphragm
Diaphragm.
weakness.
Okay.
Yeah. Yeah, I'm not sure. I'm sorry.
No, that's fine. Well, thank you very much, Dr. Cow. We appreciate your time today and thank you so much for being here.